So I'm going to give you a brief talk on some applications of ultrasound for particular infectious diseases. I got an email like 3 days ago pleading and begging if anybody can, provide a lecture. So I kind of looked this together in like the past 24 hours, kind of like a hodgepodge that I kind of coalesced for you guys. I'm trying to look at a few applications here for you. All right. So for the sake of time, because we have like 40 minutes or so, we're not going to cover appendicitis, we're not going to cover cholecystitis kind of infections. I know, like when you're on rotation, those are kind of, the things that you want to master, but for the sake of time, those lectures in itself can take an hour each. So we're just going to focus on just the bottom here, particularly things you can come across in the clinical area, which is mostly soft tissue infections, looking at deciphering, what lymph nodes look like, so you know not to lance those. And then, we're going to look a little bit about pneumonia. I just want to kind of throw some things in there because really, when you look at it, look at some literature. Actually, I find that ultrasound is actually a little bit better, more accurate than your typical chest X-ray, especially those portables that you get in the clinical area. So, and then I just going to throw a quick video and just talking about how you can use ultrasound to help guide you when trying to do those lumbar punctures. All right. So first topic we're going to get into is just looking at cellulitis. All right. This is the typical skin. So here's some stuff I'll talk about in a second. Like anything else, when you look at ultrasound images, I show the pathology. We also have to know what's actually normal. All right. So normally this is actually the skin. What you see here is this nice striated appearance here. This is, we know, is muscle. Up here we have the skin. But unfortunately, what you look at here, the epidermis is so thin. You really have to pick it up. What you really pick up is a little bit more of the dermis and actually some of the subcutaneous layers. And the subcutaneous layers, will vary depending upon each patient. How much they consume, how much compounds they consume. Right? So, when we talk about cellulitis, whenever we use kind of throw the term cobblestoning, all right? Those are these like lace-like little pockets, and not just like fluid or edema that's getting into the soft tissue, into the dermis and subcutaneous tissues, right? If you like to travel, I'm sure a lot of us like to, and you go to Europe and whatever else, you see all these cobblestone streets. So it's kind of like if you're walking, down the street in Italy, whatever else, it looks like a cobblestone street. And here's those kind of images now. What you can see here, again, going back to the image we picked up way down here, is nice and dark, is the striated muscle. As you get up to here, you get the fat and the dermis, and you can see here this edematous tissue, this film tissue, and edema kind of falling in between the pockets here. Right? So you can call it cellulitis. But what I said is it has some features of cellulitis, because I still think it's a ultrasound with a clinical diagnosis. And we'll try to talk about that when I talk about some of the fake outs. Right? Because if you have this in somebody who's got let's say this is a lower leg that's red, inflamed, got fever, then most likely very tender that area, you're most likely concerned that it's cellulitis. But the patient does have some erythema, but has no pain, no warmth, nothing, and they have bad CHF because of the lower legs, you may be thinking that this may not be actually infectious. This may be just some leg edema. But like anything else with ultrasound, you have a dual screen feature on your machine, and what it can do is it can split the screen for you. This is the normal side. This is actually the normal anterior tibia. All right, this is the anterior tibialis muscle, and here you have epidermis and dermis. Look how thin that is. And then when you compare that to the opposite side, which is all cellulitic, and you're concerned for cellulitis, look how much edema develops into that dermis subcutaneous area, and how much it displaces the tissue. Right? It's the same depth, the same location. What's important though is when you have cellulitis, our other idea we're worried about, or the thing we're worried about is whether or not is there an abscess, right? Am I going to have to lance this open? Am I going to have to aspirate, am I going to slice and dice and like do procedures here? Is that going to be possible? So like anything else, you want to fan over the area of interest. As you can see here, you have some cellulitis features that way you pick up here. This was just picked up last month by some of your colleagues. You have an abscess. Which is the next part we're going to talk about, right? Defining ultrasound findings of what an abscess is. As you can see here, this one looks like it's someone's bladder. This is actually an abscess. Some of the features of the abscess, as we'll talk about, is it's mostly anechoic. It could be hypochoic with internal echoes. But many times also you see this acoustic enhancement. Right? When I use the term acoustic enhancement, pretty much what that is as sound beams travel through a medium, particularly if it's fluid filled, it doesn't attenuate its strength. So when it comes next acoustic impedance, which is much higher, it reflects and it causes brighter. So sometimes what you have to do is just turn down some of your far field gain. All right. So anything else when you talk, when you're rotating with me or working clinically, usually ultrasound's there to help kind of guide some clinical questions. And I don't like it when you come and says, I have no idea what this belly pain is, so I just want to scan everything. I want to know whether or not it's just thinking that, oh, this patient has abdominal pain, this pain's the epigastric, upper quadrant regions. I want to make sure this is not cholecystitis. Sure, that's great. It makes it much easier. So if you come in with same kind of more dichotomous question, maybe make it easier, right? What I want to know, is there pus present? Can I locate the best pocket? Also, how deep am I going to have to go? All right? Like anything else, when it comes to looking for an abscess, you also have to look for other surrounding structures. I didn't put a picture in here, but like anything else, is there any neurovascular structures? Is there any, like artery or vein? And like anything else, you have Doppler, you have colorful on your ultrasound machine. All right, like anything else, scan the affected area. It came out a little darker than expected, but this is a woman's left breast, and this is a woman's right breast in the same area. And as you can see here, there is a pocket and what's being actually pus. So, anytime you're doing soft tissue, what is the transducer of choice? Well, we know it's the linear transducer, or any high-frequency transducer. Why? Because these structures are very superficial, so I don't need depth, I need resolution. So unfortunately, with ultrasound, it's a trade-off, it's one or the other. So high-frequency probes can give you less depth, but better resolution. Many times what I kind of do when I'm looking for some of these infections or whatever else, these probes harbor, bacteria, and they're actually literature looking at it, and actually they're pretty good at not really harboring bacteria, as long as you wipe them off and you clean them. You don't leave bloody, gooey junk on the machines. Yes, right? So, but like anything else, sometimes what I'll do particularly is I will sometimes put a little bit of tegaderm over it, right? Provide a little protective barrier and just quickly peel it off. It's just preference. Anything else, my new thing now is I don't do much clocking because the screen doesn't fold. But like anything else, because by the time I get to the first thing, you're already read through everything. But like anything else, when it comes to abscesses, it varies. Many times they're going to be anechoic because they're fluid filled, but they can have a lot of internal echoes. And what I'm just going to do is, again, I'm just going to give you a lot of pictures. So here's an abscess. Fan through it. As you can see, it's anechoic. It's got irregular margins. That's an acoustic enhancement, some internal echoes. Right, this is an axillary abscess. Like anything else you do, you put color flow on. What does the color flow show? The color flow is more around some of the periphery, not internal. And we'll talk about that in a few minutes. Again, here's a patient's body abscess, right? Just again, to show you some more pictures here. Again, it's anechoic, irregular margins, got some acoustic enhancements. What's nice with ultrasound is you can actually see how far you need to go. Right? I mean, you have the depth markers here. In this case, it's 2.5. So these are each 0.5 centimeter markers. But you can use the calipers here to kind of tell you how far you're going to have to lance to get down to that pocket of pus. Other things, especially if it is really bad, sometimes you can see what's called a swish and swirl pattern. All right? As you can see here, as you kind of compress the line here, you just watch it. Kind of like oozes out. Pretty disgusting, right? Don't worry, I got a more disgusting video coming up pretty soon. Don't worry about this. So just make sure you have a full stomach when we see that video. You're going to love it. Most importantly, what I think is really important, especially when we get to the buttock area, is sometimes you want to know whether or not there is an abscess, first of all. If there is, how deep does it go? Right? So we had a case in the fast track overnight, years back. It was kind of like towards the perirectal area, so they're just like, all right, we're just going to, they just lanced it, and, I was like, let's put the ultrasound on. So it's a very extensive one. So we called surgery, and the resident came down and said, let's get the CAT scan, and I said, I don't think that's necessary. I actually got Schwartzman to come down, and he saw the ultrasound images of the OR, 500 cc's plus. Nasty, right? So the patient got rectalized 3 times times. Definitely. What's important, this is a case report which Saki and I just put together. Shout out to them, right? Is actually you can use ultrasound to measure your outcome, how well you actually perform the procedure. As you see here, it's anechoics and internal echoes, a little acoustic enhancement here. Any idea where we are? Not me, not sure.
Yeah.
The rest. All right. What you can actually do, many times, it's not the standard of care. Usually, like IND surgery console. We actually took an 18-20 gauge needle here, and actually under ultrasound guidance, aspirated out 2 cc's of pus. And here you go. It's gone. We wound up giving antibiotics anyway to be on the safe side. 6-9 months later, it's still doing well. All right, so you can actually use it to measure your outcome. You can actually do it after you land to see whether or not is there still a pocket of fluid there, because there's some loculation. You try to go in, you try to break them up. You're not sure if you got them all. You can use ultrasound to make sure you have nothing left. It's important to know there are certain areas where it's very superficial. In that case, you worry about the hands, the fingers, the feet, the toes. Right? So how am I going to be able to do that? Right? The ultrasound probes have a certain kind of what's called a focal zone, an area where the best resolution. And many times, if you have the probe, it's actually, if this is the probe itself, right? And here's my skin of interest, and as soon as I put it down, right? And my abscess is so superficial with that probe. Usually the focal zone is usually middle of the screen. It's beyond that. So I have to somehow raise my probe up so that I get the best resolution of that area. Particularly, like I said, of the hands and the fingers. That makes sense. So one thing you can do is you can do stand-up pads. You can take a glove, fill it with fluid, and all of a sudden now I can get a better look at what's very superficial on the hand and the feet. Right? Other things you see in work with me is I take a big bucket filled with water and just put it down. As long as these ultrasound probes are not cracked and have no exposed internal components, you're not going to get electrocuted. All right? So they can be immersed in the water as long as they're not floating. And here's in particular, right? You have that finger and you want to know, hey, is there actually an felon or not? If you can look closely here, so this is in a water bath, so this is all fluid here. Here's the finger, right? This is actually the bone. So unfortunately, I don't see the rest because remember, bone is a strong reflector of ultrasound. Because it's a strong reflector of ultrasound, I'm not going to see beyond it. So here is the bone. So here's the tip of the finger, of the left index finger, and as you can see here, everything looks pretty good, right? If you look very closely and very subtly, what do you know? Well, the dermis and everything else is very thickened, and what else do you have here? Yeah, so here you go. So we went lateral, whatever else, and then, drained out, drop it off. So some other things you may want to try to use. All right, so let's throw a normal case here. All right. What are you thinking? Yeah, something in the back, right? Percenter calculator, and you're like, meets it, maybe not. What you can do is you're looking for that tonsil, right? So we use two kind of approaches. You can do the intraoral approach, which I'll show you, or you can do the transcutaneous approach. This is actually in a review article I just published this past year, looking at each of the ultrasound diagnosis of PTA. And so in this case, we're looking at the transcutaneous approach. Now, kind of bear with me. What you're taking is you're taking the transducer just under the angle of the mandible, right? And what you're doing is now you're taking it and you're just now trying to angle. Many times it's better to start on the bone because you can see the bone. And like anything else, you start fanning towards the back of the throat. And so like anything else, you're going to get certain structures. So I split this up for you. So this is the normal side. And what you're going to see here is you've got the gland, right? You have the submandibular gland. Beyond the submandibular gland, you're going to have the tonsil, and the tongue sits all the way back here. So this is the normal tonsil. I'll tell you about the specific dimensions in a second. And like anything else, if you look here, this is a normal tonsil, and then this is the other tonsil on the other side. It's a little swollen. So with the transcutaneous ultrasound approach, it's very operator dependent. Sensitivity and specificity is not too bad. Like I said, it's all dependent on how well you are as an operator, right? And this is going to be good, especially for some of those kids, right? Kids are not going to want to open their mouth. They have a lot of trismus, or you're now getting some of those bright patients that are like, you're gonna stick that thing in my mouth, and because the ICT is like, didn't you just do it on my girlfriend about a minute ago, for her pregnancy test? But anyway, so what you have here is, up here's the skin, here is the submandibular gland, right, and here you have the tonsil. If you look closely here, you can see anechoic fluid, a little acoustic enhancement. Right here you have an abscess. The tongue is way back here. One thing you can have the patient do if you want is you tell them to, collect a spit or bring a little bit of a cup of water and have them swallow. And you're going to see this move in there. This is the base of the tongue, right? Because when the tongue swallows, it pushes up against the back of the palate and the tonsils, and down the hatch it goes. This is what you may be more antiquated with, which is the peritonsillar abscess from the intraoral approach, using the intercavitary transducer. But anyway, so what you're doing with the transducer, I'll show you, is like here you have the tonsil, here you have your abscess, and what's nice is you can actually put color flow on and see where your structures are. In many cases, here is your carotid artery. Most of the time, the carotid artery is sitting back about 3 to 4 centimeters back there, and it's nice. You can actually measure how far you need to get into that pocket. Right, if you have some depth gauge markers here, you have half, 1, 2, 3, 4. So here's that centimeter, so you can take your 20, 18 gauge transfer needle, cut the cap about 1 centimeter, and you know you're going to be able to get in that pocket and not go deeper, and potentially get into this. Like anything else, people don't report this. And I think they say because they're really that good, or they don't report it because you want to be in the literature showing that you are incompetent physicians. Right. So, but normally the tonsil, it depends on the size of the person. It's about 10, 20 millimeters, 1 to 2 centimeters. If you have something that's over 2 centimeters, right, and you have like this little striated appearance and every stuff into it, then that's something more that's concerning for peritonsillar cellulitis. And as you can see here with this one, you can see that there's no pus pocket. So therefore, you're not going to have that dry tap and save the patient from agony and blood just oozing in the back of the throat. Again, this is very operator dependent. The sensitivities and specificities are up there. The higher it is for the more experienced sonographers. So here's the video for you. So on the left is the screen. This is actually itself. So here's the disgusting picture. So here you go. Look closely. Here's all the pus. So here it is. So usually when you go in, you go in the transducer in like a transverse plane. As you can see, going in there, here is your big, huge abscess. Right? Located it, you know how far you have to go. Carotid's back there. Just watch it one more time.
Yeah.
Yummy, right? It's good to see it 9 o'clock in the morning.
Dr. Secko, for the transcutaneous, like are there, it's obviously fine to go through the gland and everything, are there structures?
There's not much really there, right? It's just the gland, and then if you look, put your finger in the back of the mouth, it's the base of the tongue. Get your finger and just look it in there, you'll be able to touch it. So, and actually, if someone has some glandular problems or mercury in school, and nothing in there, ultimately just in the back, and not that much. So like anything else, you got to understand that there are some fake outs here that can kind of fool you, or you just have to be cognizant of, so you don't kind of inadvertently, lance or aspirate something that's, fine. Here's one structure in the lower, in the neck. Any idea? Yeah, it's just a large. So like anything else, this is up in the cervical, anterior cervical change, and depending upon how big it is, you see this big, huge heterogeneous, kind of like a pseudo kidney. If you put colorful on it, it's like a big tree budding pattern to it, right? Much different, right? If an abscess, the vascular flow is going to be around it, right? So lymph nodes are very vascular, right? They're part of the lymph system, they're part of infection. You need blood supply, you need blood, fighting off an infection. It needs a good blood supply. So pretty much what you do is you have a highlight. It almost looks like a kidney, right? Kind of a pseudo kidney, especially when you put vascular flow on it. Here's another one in the lower leg, right? It's kind of, just mixed echogenicities in there. much different than the surrounding tissue, little loose enhancements, it could be small, like little pocket abscess. Put a color flow on, again, see color flow around it, color flow within it, right? Abscesses usually don't have color flow within them unless it's surrounding a vascular structure. Which is not good. It's in the patient's thigh. What do you say? Abscess? Well, it's hard to say, right? Like anything else, we hopefully did a good history and physical. And this patient says, oh, I was riding my bike, I hit a rollerblader, went flying over the handlebars, hit my leg up against the curb. Hematoma, right? So you have to kind of use it in the clinical context of what's going on, right? I will tell you that as I saw this as a thigh hematoma, working with the resident kind of constant trauma because of other primary trauma, and all of a sudden, you know, a particular female trauma surgeon came down and says, please CAT scan the leg. And the CAT scan the surgeon. So she got unnecessary radiation or something that's safe. All right, so that's something you want to focus on. Granted, if she came back as more swollen, they're going to concerns of cut. Again, like I showed you one of the beginning slides, you know, just general leg edema, right? People have CHF that are definite states, you know, they can just have pooling or, you know, vascular insufficiency. But a pooling of blood or fluid in the lower legs can also give you that kind of cobblestone appearance, right? But the leg's not erythematous, not tender, not swollen, whatever else, you know, maybe not likely. What about this image? Heard something.
It's like a muscle involvement. There's like a demon in the muscle.
Muscle. If you look closely at it, like anything else, you know, there's still parts where the physical exam kind of supersedes ultrasound. Ultrasound is used to kind of just reaffirm your suspicion, right? The patient has a lot of crepitus over this area, right? This, as you can see here, is hyperechoic with dirty shadowing. Neck fascia. So you can pick up bulge neck fascia on ultrasound. But again, it's more of an still clinical diagnosis, but if you want some to reaffirm your suspicion of a certain area, yes, you can look for it as well.
What is that? That's making that sound.
This tear. Remember when you did the lung, right? It's very hyperechoic. Like anything else, you get this like kind of dirty shadowing appearance behind, especially when you look for bowel in the abdomen itself. Again, it's dirty shadowing. Okay. The last major topic before getting to this level of function. We'll talk a little bit about pneumonia. Okay. So I know some of you are very good at doing some thoracic ultrasound. I know some of you are still learning it, so I'm just going to kind of review just a little bit about lung ultrasound. So like anything else, when you want to look at the lungs, you want to kind of look at all areas, and many times you kind of want to divide the chest into kind of two hemithoraces. You have the right hemithoraces, you have the left hemithoraces. Many times what you guys do when I'm reviewing images, watch, you just kind of just look at the anterior and the lateral base. We're going to talk about also incorporating another part of the thoracic cavity. All right. But like anything else, when you want to look at the lung, you always want to kind of be in a sagittal plane or in a coronal plane. You don't really want to be in transverse between the ribs. You want to kind of be in this direction. All right. What are your transducers? Well, it depends on what you're looking for. Right? So many times, you know, we like to use the linear transducer because we want to look for pleural sliding, right? And I think this is very good for when we're suspicious for pneumothorax. But when you want to look something deeper into the lung parenchyma, right? These only give you a depth of maybe 6 centimeters, maybe 9, depending on which company transducer. Right? So unfortunately, the hemithorax is not 6 to 9 centimeters deep. It's much deeper than that. It's 21 plus centimeters. So you need one of these lower frequency, or the aka abdominal probe, to kind of look deeper. So here's a linear image of the lung, As you can see here, you can pick out some structures. These hyperechoic, with shadowing, we know are the ribs. In between those ribs is our pleural line. Right? Our artifacts are going to be generated off the pleural line. That's what lung ultrasound is. It's about interpreting artifacts. I'll just try to give you some nomenclature for some of the novice sonographers out there. Right? If you ever use the term B-lines, here are some B-lines. B-line, here's the rib, pleura. You can see the A-line before you saw some B-lines. B-lines are artifacts that generate from the pleural line. The erased A-lines, they go over the whole length of the screen, all right? So one B-line does not have much meaning, okay? Even you or I can have just one B-line. We're looking for 3 or more B-lines per interspace to be of some significance, all right? So if you have somebody who's got a fever and a cough, and you see in the upper segment of the right lung, you see this scenario, and you look everywhere else in the lung, and it's all A-lines, then you can be suspicious that this is probably just a pneumonia. Many times you guys ask me, what does a C line look like? Here's your C profile. All right? We're going to talk about some of these things here. It's kind of like a C shape upside down. As you can see here, it's got some serrated margins and whatnot. All right? That's a C profile. Okay? That's the some of the tremor, right? So how good are we, right? With the diagnostic accuracy. Auscultation, awesome. Every time, right? Chest radiograph, specificity was high, sensitivity is not. Something in the lung literature, much better. All right, but this is, when you're looking at the lung, you're not just looking in 4 places. It's a more thorough inspection of the thoracic cavity that you're trying to do. All right, if you look at it, many times people will divide the thoracic cavity into quadrants, zones, however you want to kind of say. What's important to know is you have to kind of make sure you look at the anterior, both the upper and lower segments, lateral, the upper and lower segments, and most importantly, which is where a lot, where you find most of these notorious pneumonia, especially these lower lobes and whatever else, is you've got to get back to the posterior segment. Right, so you got those patients that are supine, you may have to roll them up, or the patients actually up, or whatever else, have them sit up for you and look in the back. So here are some of the sonographic features that you want to look for when you're looking for pneumonia. I highlighted some of the most important things, right? It has to kind of arise from the pleural line. To see clinically significant pneumonia, which I had on the lower slide, it has to come up to touch the pleural line, right? If the lung is normal, you're just going to see your normal typical artifact. You're not going to see the pneumonia underneath it. Right? To be clinically significant, it's got to come up and touch the pleural line. Many times you're going to do irregular or serrated margins, and like anything else, you're also trying to look for these parameters. All right? Some of the colleagues doing some rotation 2 weeks ago. Also try to maybe label so we know which side of the lung you're on, right, left, upper, lower. So and as you can see here, some of those features that we're talking about. Right, you see a little bit of aerobograms in there, you see different echogenicities, you see serrated margins. It'd be nice if you could just see this, right? This is like the most extensive hepatization that you're seeing, where unfortunately the patient has a pleural effusion, a little bit of a peritoneal fluid. Here is your consolidated lung, and here's some of those aerobograms. Right? I don't want to kind of confuse you, but I do have a clip here at the end. One of the hard things for us to decipher too, especially for some of these patients, especially in a nursing home and they're more bedbound, atelectasis can look like pneumonia. So sometimes we say you have to kind of look at those aerobograms. If they're more dynamic, you're concerned with more pneumonia. If they're just static and not moving, it's just more atelectasis. I just kind of err on the side of caution, especially with our patient population and how compliant they are with medications to follow. I err on the side of caution and treat more vigilantly with antibiotics. Say it's going to be later on anyway. What's important to understand too is you can have lung consolidation and it can coexist with any kind of interstitial syndrome, right? We coexist with having your typical B lines, right? Just an evolution of the disease process, right? The abdominal's got to contact that pleural line for you to see it, right? So if there's a pneumonia that's under here, this has to touch the pleural line. That's why I can see it very nicely. Here it's just part of the interstitial syndrome at this current point in time. On the last few slides here, I'm just showing you different types, subtle things of what pneumonia looks like. Again, there's a little C profile. There's the base of the lung. Interstitial syndrome with some consolidation behind it. It's there, bronchograms here in the right base. There's the worst case scenario, it's just total hematization. Alright, hematization is the sonographic term for pretty much, it's kind of like looking at the liver in the thoracic cavity. So that's why it's called hepatization, right? So here's an abdominal organ, and pretty much here's the consolidated lung here, which is just almost as if it's migrated into the chest. Makes sense. Okay. Consolidations, there are bronchograms, you can see the heart rate behind it.
So what's the difference between the C line and the, clinically, what's the difference between C lines and hepatization?
So, getting back to the nomenclature, that was kind of coined back in the chest article by a French intensivist. So, pretty much what he was saying in the ICU for some of these patients that went having pneumonia, they let CTs after the ultrasound, is that when he saw that kind of C profile, it was very more pathognomonic for them that it was pneumonia. Hepatization is just more expensive. Hold on here, think about it. Right, that whole lobe or segment of the lobe is now consolidated. The C profile is just only a small portion. Earlier quality. Better way to put it. All right, got the nursing home patient, nonverbal, doesn't give you much information. You can't get much history. You have to kind of scribble scratch to find out, what they did in the nursing home. But like anything else, you have to intubate the patient because of restored stress. Right. So you get the chest X-ray, it's kind of hazy and blurry. So let's see what happens maybe with an ultrasound. So this is the right side. Here's the liver. A little pleural effusion. It's also important to know, as you can see, you can see a little bit of what's called the spine sign. So when you have the extension of the thoracic spine into the thoracic cavity, right? Because it usually just ends with the liver, right? So anytime you have fluid or you have a consolidated lung or whatever else, you have echoes that can now make its way through. The next includes the pedians, remember, because we're coming from this direction, would be the spine. When you see the spine of the thoracic, then you know something is developing in the thoracic cavity. Right. Same part of the lung, and I was hoping you can kind of appreciate it more, right? So you have the parapneumonic effusion here. You can see the mixed echogenicities here. You see the air bronchograms. Now if you can pick out really subtly, look at this segment right here. Right? That's a dynamic air bronchogram. Right? That's air that's trapped within that consolidated lung as you're trying to breathe, and it's still moving back and forth, back and forth. So it kind of gives that beaded appearance. You know this is definitely more like a pneumonia. Like anything else, you want to make sure you get both sides because you never know, and you may miss out that this patient actually has not just one regular lobe, but has all right. Almost done. Sign out time, right? You're in APOD, sign out, busy night. Like, I got this 20-year-old guy, fever, next stiffness. You look at him and you're like, here's the best part. Sign out, follow up the labs, and oh yeah, I think he needs the LP. Nice, right? So here's what we gotta do, right? So, you gotta do the lumbar puncture. So like anything else, in ultrasound, or when I teach ultrasound, I hope I try to use it as like an adjunct, another diagnostic tool, but there are certain procedures that you still need to know and understand how to do without an ultrasound machine. Because, once you graduate here, you may go to a place that doesn't have one, or you're going to have to acquire one, or one's archaic, or has one but doesn't have the right probe. So like anything else, you should try to do that. When you're with me and you try to do central lines, when you touch the IJs, they're just like, it's ultrasound. But if you want to do something like a symplectic, and I think that's something even I've tried to do myself, that should be done based on landmarks, you feel comfortable that it's some emergency had come along, or whatever else, you know how to do something without ultrasound. Though we know the literature supports the use of ultrasound with guidance and something like that. Same with lumbar puncture, right? We all know iliac crest from L4 or whatever else. Right? But sometimes people's body habit is, right? There's big skin folds that kind of flap around the back, and you're like, oh, I can't palpate those landmarks. So maybe sometimes ultrasound can help you out with that, right? Courtesy of a negative, well, we have Highland, he's a former graduate. So here you can see you can use the ultrasound to help kind of guide it. So what he was doing initially is taking it in a transverse orientation to find out where the spinous process is, and then going into a sagittal probe to find out where those are, and taking with a marker, marking out that space. And you can see here, here's still those marker marks, and there is yours. First try? First try. So this is kind of what we're trying to look for. So if you're in the sagittal plane, which is if you're in plane in line with the spinous processes, you're going to see the ligamentum flavum right here. And what you're going to pick up for is, remember, the bone is hypercoic. So here's your hypercoic spinous process. Here's your hypercoic spinous process. And you have to be very careful, right? Most of the time, people in the lower lumbar area, it's pretty shallow. Despite how fat you are, there's not always much tissue there. So you have to be careful, because if you fan a little bit too far lateral, you're trying to get those pedicles. And you're going to see something very similar here, where it's going to be a little deeper. So you have to be very careful that you have the pedicles over here. And therefore, you keep going to lateral, and especially if you're on the left side, all of a sudden you aspirate blood, then, good luck with that. Like anything else, this is a transverse view. Right, again, the ligamentum, here's the spinous process. Right, and what you do is you just take that, you can mark that, and then you just come down and find where the next spinous process is, you mark that, and you know there's a space in between, and if you were to go back, you know that this is where you're going to go. There's your spot. Right, but like anything else, you use as a marker as a guidance. But again, like anything else, I always try to encourage you to try to do it with, just based on landmarks, but if you feel like you're struggling, you can use the ultrasound machine. Just like anything else, when you have the patient, in the fetal position, it can be a little bit too far rotated and whatever else, so you may not have the proper alignment in this. I didn't throw much literature in this talk because I just thought images are more important. I ran looking at ultrasound group, landmark group. As you can see here, pain was much less with ultrasound. Number of attempts, number of traumatic procedures, and time are all reduced. Right? Particularly when you start looking at the BMI, here's the ultrasound group here with a large BMI greater than 29. There's the landmark group. If you look at the timing, look at this. 4 minutes, 9 minutes. It's twice as long, more complications, more attempts.